Dr. Ayman. So it is my pleasure to present the next speaker. It's Dr. Riad Elfakih, who's a consultant in hematology and stem cell transplantation in King Faisal Specialist Hospital. He's also an associate professor and head of the research unit over there. Dr. Riad will share with us two abstracts regarding the use of CAR T therapy in two different diseases, in follicular lymphoma as well as CLL. Dr. Faqih, you may begin.
Thank you much, Mus'ab, and I would like to thank the organizers for inviting me. Can you see my slides?
Yes, we can.
Okay, so I was asked to talk about two abstracts addressing the use of CAR T-cell in two new diseases without FDA approval, the follicular lymphoma CAR T-cell trial and the CLL CAR T-cell trial. So we will go over the ELARA and the TRANSCEND CLL trial. This is the first trial. This is the ELARA. And as you know, follicular lymphoma is an indolent disease, but about 20% of the patients will have disease recurrence within the first 2 years of treatment. And these patients don't do well, actually. Tisa-cel, which is Kymriah, is an anti-CD19 CAR T-cell approved for ALL and diffuse large B-cell lymphoma, but doesn't have approval in follicular lymphoma. So this trial is studying this CAR T-cell product in follicular lymphoma, with a primary endpoint being the complete response rate. So here's the schema of the trial, screening of the patient, enrollment, then manufacturing, which takes like 2 to 3 weeks, lymphodepletion thereafter, and infusion of the cells. And bridging chemotherapy was allowed on this trial. Eligibility, patient has to be more than 18 years, all grades of follicular lymphoma except 3B, relapsed refractory disease, failing 2 lines of therapy, and no evidence of transformation. Of course, patients should have not received anti-19 therapy nor allogeneic transplant. And this is the lymphodepleting therapy, Flu-Cy, regular Flu-Cy. Bendamustine was also used in some patients. The dose of the CAR T-cell ranged between 0.6 to 6 by 10 to power 8 total dose. This is not per kg. And again, the primary response, endpoint was complete response rate. Secondary endpoints, overall response duration, PFS, OS, safety, and cellular kinetics. So they started with 98 patients, 97 were infused, 1 was not, based on his physician decision, and 97 were available for safety assessment. 94 were available for efficacy assessment after 6 months of follow-up. So the median follow-up for the infused patient was 10.6 months. Here you see the baseline characteristics, median age 57, which is expected in this disease. This is a disease of the elderly. Selected group, all the patients had good performance status. As you see, the majority were 0 and 1, a minority were 2. But the disease itself was pretty refractory and high risk. You see a good number had multi-disease, advanced stage, advanced FLIPI score. Median number of prior therapy was 4 and ranged between 2 and 13. And the patients with POD 24 were around 60% of the total population. Refractory to more than 2 regimen, 76%. And here you can see the types of therapy received. The majority received chemo immunotherapy, and some received PI3 kinase and R2. This is the safety profile. Again, 97 patients, and the safety was available on all of them. Most of the patients got side effects, the usual side effects. Grade 3 to 4 adverse events were seen in 76%. Death was reported in 3 patients, and all of them were due to disease progression, not toxicity. Here you can see the CRS management. 34% of the patient had to receive tocilizumab to control the CRS, and 6.4% had corticosteroid. In regards to the neurologic adverse event, none of them were more than grade, one of them was grade 3, and all the others were grade 1 and 2. And here you see again the cytokine release syndrome. None of them was grade 3. Of course, infection and the other expected side effects were seen as expected with CAR T-cell, like B-cell aplasia and neutropenia, cytopenia, and infections, but none of these were outside of the expected range. Again, concerning the specific side effects of CAR T-cell, cytokine release syndrome, all of them were 2 and below, grade 2 and below, and neurologic side effects, 1 only was grade 3. Here you see the primary endpoint. The CR rate was 66%, the PR 20.2%, and the overall response rate, which is the primary endpoint, was 86.2%. And here you see the median duration of response after 11 months of median follow-up. The median duration of response was not met. Interestingly, 12 of the 31 PR seen on that trial converted to CR between month 3 and month 6. So some patients started with a PR, and later on the response was deep enough to reach CR. Per subgroup, the efficacy, as you see, all subgroups did benefit regardless of the age, sex, number of prior neoplastic lines, as you see here, less than 2, 3 to 4, and more than 4. The type of therapy and prior autologous transplant, disease status at the last therapy, like refractory or relapsed, and POD 24 patients. So all subgroups did benefit from this treatment. This is the PFS, as you see here. Both median PFS and OS after 11 months of follow-up were not reached, and the estimated 6-month PFS was 76%. So all in all, Tisa-cel demonstrated high rates of durable response, with an overall response rate of 86% and a CR rate of 66%. This data suggests that CD19 CAR T-cell is effective in relapsed refractory follicular lymphoma patient. Concerning the side effect profile, no high-grade CRS was reported. As you saw, all the CRS were less than grade 3. In regards to the ICANS or neurotoxicity, 1%, only 1 patient had grade 3 toxicity. No mortalities were reported due to the treatment. 3 mortalities, 3 cases died, and all of them were due to progressive disease. So all in all, Tisa-cel is a safe, promising therapy in this type of patients. We move on to the second abstract, and this abstract is a phase 1 cohort trying the liso-cel combined with Ibrutinib in patients with relapsed refractory chronic lymphocytic leukemia. So as you know, targeted therapy are now available for CLL. We have many options. All these options are effective, and with the BCL2 inhibitors, we are reaching minimal residual disease negativity. However, this disease, as you all know, keep relapsing even with these effective therapies. Now, regarding the Ibrutinib, And mouse models, it showed that it improved the expansion of CD19 CAR T-cell therapy. When these cells are exposed to ibrutinib, the expansion is expected to be better. And concurrent ibrutinib therapy improved engraftment and the efficacy of these cells in mouse models. Recent studies, phase 1 and case reports have described that the addition of ibrutinib to CD19 CAR T-cell therapy improved the response rate and at the same time reduced the toxicity. The liso-cel is an anti-CD19 directed CAR T-cell therapy, and it is composed in a way where the CD4 and CD8 ratio of these T cells are equal. So this report is an updated report of this phase 1 trial, and after a median follow-up of 17 months of these infused patients. Here you see the schema of the trial. Enrollment, leukapheresis, production of the cells, and before starting lymphodepletion, the patients had to have measurable disease, so negative MRD were not allowed on this trial. Then flu-cy lymphodepletion was done, and the dose escalation trial, the dose escalation part was started. Then the dose level 2 was chosen for the dose expansion, and patients were followed up. Regarding the eligibility, so these patients had to have relapsed or refractory CLL. They had to fail 2 lines, and ibrutinib, as you know, this trial is combining these cells with ibrutinib. So all patients had to have failed ibrutinib. So it's either progressed on ibrutinib or received ibrutinib for more than 6 months and achieved less than CR, or they had resistant mutations to ibrutinib, and prior ibrutinib did not have contraindication in these patients so that they can receive it. The primary objectives were the safety and to determine the recommended dose, and of course the other endpoints were anti-tumor activity and cellular kinetic profile. So here you see the patient's characteristics. Here you see for all patients. Then next you see the dose level 1 patients and the dose level 2 patients. 4 patients were dosed with the dose level 1, and then after determining the safety of this dose level, 19 patients were dosed with the dose level 2. So as you see, the median age is 61. This is a disease of elderly, and the majority were males. Median time since diagnosed was 120 months, around 10 years as expected in CLL. Some patients had bulky disease, and as you see here, in regards to staging, RISE stage 3 and 4 were around 43%. High-risk features, as you see here, deletion 17p constituted 40%, and 35% had TP53 mutation, so pretty high-risk population. Prior ibrutinib exposure, all of them again had to have exposure to ibrutinib, and they had to fail ibrutinib or exposed for 6 months and did not achieve CR. So as you see, 100% of the patients received ibrutinib. Bridging therapy was allowed, and as you see, 40% of the patients were or received bridging therapy. So here you see the endpoints, the toxicity profile and the safety of this combination was the primary endpoint. And as you see here, neutropenia and cytopenia was seen as expected. However, the CAR T-cell specific toxicities like CRS and urologic side effects were not out of range. As you see here, all grade CRS was 78%, was seen in 78% of the patients. And you see that in dose level 1, all patients had CRS, however, 74% only in dose level. So it's unrelated to the dose level. Median onset of CRS was 7 days, and it lasted for 5.5 days. Now, the majority, 74% of these patients had CRS grade 1 to 2. Grade 3 CRS was only seen in one patient with the dose level 1 as well. So this data suggests that the higher dose level, which is dose level 2, did not correlate with a higher CRS incidence. In regards to the neurologic side effects, as you see, 7 patients, or 30% in total, had the neurologic adverse events. 3 of them, so 13%, 3 of them, 13% were grade 1 to 2, and 4 of them were grade 3 toxicity. Most of the toxicity, the neurotoxicity, was seen actually in the dose level 2. And here you see the treatment received by these patients, secondary to toxicity. 3 patients had to receive tocilizumab to control their disease. 3 had to receive corticosteroid, and 5 had to receive the combination. Again, here you see the safety profile regarding the Ibrutinib, because this is a combination trial, as I said. And you see here that grade 3 to 4 Ibrutinib-related effects was seen in 40% of the patients. And as you see, around 75% of the patient received more than 3 months of the combination. So basically, it was a tolerated combination, and dose interruption or dose stopping was not required. The median duration of Ibrutinib exposure was 141 days, and the median duration of Ibrutinib therapy after infusion was 97 days. So these are the Ibrutinib side effects. You can see here, cytopenia, AFib was seen in 1 patient, lung infection in 1 patient, and infection in 1 patient. The side effect that required dose reduction were AFib and the grade 2 fatigue. Here we see the response rate, which was a secondary endpoint on this trial. And as you see here, the overall response rate was 95%. So 21 out of the 22 infused patients achieved CR/CRI. As you see, no PRs on this trial with the dose level 1 and dose level 2. And here you see the MRD data, as you see here. In blue is blood MRD, and in yellow is marrow MRD. So very high rate of MRD negativity, both in the blood and the marrow in patients who achieved CR. And again, 95% of the patients achieved CR. This is the response over time, as you see with the dose level 1 and then with the dose level 2. And most of the response are still ongoing. So all these responders, sorry for that, achieved the response by day 30 after infusion of the cells. And most of the patients who responded were still maintaining their response at around 6 months. 2 patients did progress due to Richter, and the patients who received dose level 2 will be followed for 48 months and reported later. Of note here, 1 patient on this trial died from complication of COVID-19. Here's the median duration of response not reached, and here's the median PFS also not reached after 17 months of follow-up on this trial. So these prelim data suggest that liso-cel combined with ibrutinib is well tolerated with low incidence of grade 3 CRS and neurologic adverse events and no grade 4 or 5 CRS or neurologic events. No clear difference in the safety was observed between the dose levels, dose level 1 and dose level 2. And the dose level 2 was the chosen dose to expand the cohort and follow them. As you saw, heavily pretreated, refractory, high-risk CLL patient did respond, and the majority of them achieved undetectable MRD. Responses were durable. Still, the follow-up is short, but as far as we know, the response is durable. Some patients achieved PR, 4 of these infused patients, and later on, with follow-up, the cells expanded and they went to CR. All in all, it seems to be an effective and safe combination, and hopefully will open the door for more therapies for these patients who have multiple relapsed refractory CLL with a high-risk profile like mutation or deletion of P17. With that, I will finish and happy to take any questions.
Thank you, Dr. Riad. Very nice overview. Can you please check if we have any questions from the chat box? Okay, so I actually have a comment and a question. In the first abstract that you shared with us on follicular lymphoma, we see that the responses are quite high in these heavily pretreated patients, and the curve and the PFS curve seems to plateau after a period of time. What I'm wondering is that, as you know, with follicular lymphoma, the story is a bit different than the LBCL, where you can still see delayed relapses. So the question is, do we think a subset of patients will be cured using CAR-T therapy for follicular lymphoma? And if, of course, we don't know the answer, but I'm curious to hear your comments on this. And where do you think this treatment modality is going to fit with the different options that we have in these patients?
Sure. So regarding the curability of this approach, it's too early to tell, you know. And as you know, this disease tends to relapse, but some patients will have very long remissions. You know, we treat patients with chemo, and sometimes the response goes on and on for more than 10 years. So it's a very hard question. What I can say, this option is a new option for these patients who failed the available standard of care. And specifically, I would say it will fit patients who relapse within 24 months after the initiation of therapy, after frontline therapy. As you know, these patients have a bad outcome in general, and they tend to have resistance to the available options. And these constitute around 20% of the follicular lymphoma cases. Typically in the past, at least myself, I used to do allo transplant for these patients. Of course, auto transplant as a first modality, but then later on, because most of our patients are young in Saudi Arabia, most of these patients will end up evaluated or end up having allogeneic transplant. So this is where I see it helpful the most. And patients who respond for more than 24 months, you know, we don't have a lot of options like in CLL. We do have nice options available. However, a good number of patients, you know, will relapse between 2 and 5 years after therapy. And these patients in our community, they are young and they will need to go through several lines and eventually will need CAR T-cell.
Excellent. Thank you, Dr. Riad. I think we'll move on to the next presentation.